As you know, this is the third oration. I have the pleasant privilege of introducing our orator today, Dr. Quresh Maskati. As they say, he needs no introduction, but for those youngsters who may not know much about him, it is worth knowing because he is a true legend, as Dr. Mahemani sir said. He is an eminent cornea and refractive surgeon from Mumbai. He did his graduation from Mumbai. He was conferred the Fellow of International Cornea
College of Surgeons.
FICS in 1986. He specialized in cornea and refractive cornea in Boston and Rochester way back in the 80s, I think. And he has been conferred an honorary FACO by the AOS for cornea, and many publications and many book chapters in his name. He is a very interesting, prolific speaker and orator, very humorous, and he has a great reputation of being a very funny quiz master and very informative one all over the world. And he has been the president of many societies, right from Bombay Ophthalmic Society, Maharashtra Ophthalmic Society, All India Ophthalmic Society, of course, the Cornea Society of India, the Manual Small Incision Cataract Society, and he has been the chairman of FBS AIOS. He has received Lifetime Achievement Awards from many organizations, and many orations he has given. He has been in the forefront of the IGO review panel, and he has many charitable interests too. He is well known mainly for his Keratoprosthesis work, the Pintucci Keratoprosthesis and the Boston Dolman Keratoprosthesis. And he is the only surgeon in the world who has experience of both these keratoprosthesis. We would like to know a little bit more about him, from himself. And last but not the least, he is the son of legendary Dr. B.T. Maskati sir, and this is the only father and son duo who has the distinction of being presidents of the All India Ophthalmic Society. No mean achievement. No family can boast of this, and he is a very sought after speaker all over the world. This is last weekend in Lahore. He is speaking in the AAPOTS, Asia Pacific Ocular Trauma Society meeting. Now, without wasting much time, I invite Dr. Maskati sir to start his oration. Today there are two topics he will cover. And the first one will be what is new in the management of non-infectious keratitis. Please.
Thank you, Mukesh. But I'm not sure whether I succeeded. I was looking very hard. At least the tie I couldn't find. So, because we want something always which is new, not to repeat. But when Mukesh asked me the choice of topic, I said, let's do something which is of practical interest and which everyone is going to see all the time. Infectious keratitis, we all tackle, we know about viral, bacterial, fungal, and there is nothing really new in that, except that pharma companies tell you that their product is much better than the other pharma companies. But aside from that, there is nothing really new to be learned in this. But the field of non-infectious keratopathy, I would call it keratitis, but non-infectious keratopathy is something which is evolving. New strategies are coming in the management, and I think it's good to keep abreast of what is happening in this field. So there are several non-infectious keratopathies. Since we want to complete the lecture today itself, I thought I'd pick a few of them. So we'll talk a little bit about recurrent erosion syndromes, filamentary keratitis, SPKs, neurotrophic keratitis, allergic conjunctivitis, and a little bit about chemical burns. So let's start with recurrent erosion syndrome, also known as RES. How do we distinguish it from something, from any other pathology differential? It has to be episodic. There has to be times when the patient is completely comfortable and times when the patient is suicidal. So there have to be times when the patient is fine. If the patient is continuously symptom free, it is not RES. If the patient has got continuous symptoms, it is not RES. So it could be due to a history of minor trauma, typically a fingernail of the child touching the mother's cornea when the child is crying, or a flying piece of paper in a school child, or a pencil tip which has just touched the cornea. So something very trivial is the trauma. There may be an underlying epithelial basement membrane dystrophy, or it could be a combination of the two. So in RES, a lot of research has gone into something so trivial. Why the research? Because it's so difficult to treat and to manage. So matrix metalloproteases have been implicated in degrading the scaffolding proteins, resulting in the erosion. There are adhesions between the palpebral tendon of the lid. Diagnosis is sometimes a bit of a nightmare. It's easy during an attack if the patient comes to us. Unfortunately, 80% of the attacks, the patient comes to you during the window period and looks absolutely normal, and you actually stain with fluorescein and nothing is happening, there is no stain. Please don't dismiss the history as being functional. Ask the patient to return immediately when symptomatic, at least the same morning. If the patient gets it at night to come in the morning, it is likely that you will pick up some stain at that time. We have very few choices as far as medical treatment is concerned. We used to try hyperosmotic ointments at night. Important thing is to continue it for 6 to 12 months. Or if the patient cannot tolerate this, then any bland lubricating ointment at night. If there is a stain, if you see a stain, you can give a bandage contact lens, or you can put a putty on the eye, bandage during the attacks. Cycloplegia gives you a lot of pain relief. So most important thing is look for associated dry eye and MGD and blepharitis, and treat these very aggressively so that you don't get a repeat of this. You can still get repeats, but less likely if you manage these. What about surgical treatments? Mechanical debridement is good. What happens is that the epithelium in that area, which is, if you've demarcated and drawn it with a paper and pen, then that epithelium there is defective. The hemidesmosomes and the desmosomes are not forming. So you want epithelium to come from far away. So remove the diseased area and remove 1 millimeter or so beyond the diseased area, so that the new epithelium will come from places which is normal and slide over and then do mitosis. So you can do mechanical debridement. You can use 20% alcohol with a well or with an old refine, just like you would do for a PRK, and you can do a superficial delamination with alcohol. You can use a diamond burr to polish the Bowman's membrane after the debridement. People have used silver nitrate as well. Anterior stromal puncture is a fairly simple procedure on the slit lamp. If you can mark it out correctly, then just take a needle, bend a needle, 24 number or 23 number needle, and on the slit lamp itself you can make multiple puncture marks. You can do this if it is in the peripheral area, because you might get a little bit of an opacity afterwards, but in the central area you can't do this. People have used YAG because they can earn more money on YAG, anterior stromal puncture, than you can earn with a needle. And you can of course do a PTK, or phototherapeutic keratectomy, if it's in the central area. And Dr. Daljit Singh used to teach the use of a Fugo plate, but I think that technique has died with it. Moving on to from recurrent erosions to another bugbear that we have, and that is filamentary keratitis. So now you see it, now you don't. So similarly, like RES, patient comes to you sometimes with a normal eye, and sometimes you can actually catch these filaments that you see. So what are these filaments? Filaments are a variable combination of degenerated epithelial cells. So patient has got dry eye. The epithelium is being cast off from the cornea, just like we get epithelium of the skin being cast off continuously. Epithelium is being cast off. Now we know our tears comprise of the watery portion and the sticky portion. So the watery portion is less. So the sticky portion, which is the mucus, that combines with the epithelium which is cast off and forms stringy layers, which are the filaments that you can see staining, or the unstained filaments that you see there. And these are firmly attached to the cornea at one end, and they are hanging a little loose at the other end. So they give the patient a lot of foreign body sensation. So basically there is an excess mucus to aqueous. The aqueous is deficient, the mucus is more, and that is why you get this. If it is the viscosity of the lipid layer is increased and the aqueous component is less, you'll get the same thing. And any cause of pathological corneal epithelium, the epithelium is being cast off more than it should, more than the eye tears can wash away, then again you'll get this filamentary keratitis. What are the examples of epithelium being diseased? Most of the time we have caused it by keratitis medicamentosa, overuse and abuse of antibiotics or steroids or whatever with preservatives, or a patient who continuously wears contact lenses for 18 to 20 hours a day. So they cause denervation of the cornea and more epithelial cast off. So these patients also usually have dry eye, and some of them may have systemic connective tissue disorders, so we need to rule that out as well before we start treatment. Now we know, like in RES, that FK or filamentary keratitis is also prone to recurrence. Filamentary keratitis, one of the simplest things you can do, because you know that it is attached to one point, so is to mechanically debride. If there are just a few, you can mechanically scrape them off, preserving the epithelium as much as possible. Unlike in a recurrent erosion, where you scrape a large area, you tend to scrape minimum and put a bandage contact lens. All these patients must have copious tear substitutes, especially aqueous based. So no matter which pharma rep has visited you last and tried to sell you sodium HA, because sodium HA is not under DPCO, so they can charge 500 rupees. But carboxymethyl cellulose CMC is under DPCO, so they can't charge more than 200 rupees. So still I would prefer aqueous based like CMC type of drops and some ointments at night. Punctum occlusion is good to preserve whatever aqueous component of the tears which are there. And here you can give a short course of pulse steroid therapy, it seems to help. One thing which also helps is long-term treatment with topical cyclosporin 0.05%. There are various percentages now. The original Allergan product was 0.05%, but then people thought that we must make something different, so they made double the strength, and then there is something in between with 0.09% and things like that, but good old 0.05% is usually good enough. Hypertonic solutions can be tried. Topical mucolytics, if you go through literature, whatever you do in making the mucomist, the injections which they give for asthma patients, that mucomist is fine. No matter whatever concentration you make it, it is still fine. Because right from 1% to 0.1%, everything is being described in books. Similarly with autologous serum, right from 20% to 50%, all of them are described as useful. So you can get it made. Our eye bank makes autologous serum from us. They bleed the patient from the elbow, then centrifuge the blood, let the cells settle down, and the serum which is there is what we dilute 1:5 in distilled water and dispense to the patients. If you want to give contact lenses, the contact lens to give is one with low water content. Hydrogel soft contact lenses are used. And of course, if you want to make money from any corneal surface disease, PTK is always an option. Dr. Sheffer Singh et al. Came out with a concept called ProKera. ProKera is patented by them and it's sold at high prices, which is nothing but two rubber rings with an amnion clip, amnion between the thing. You can make your own ProKera with amniotic membranes and bits of IV tubing. Moving on to the third corneal lesion, which is again an irritating lesion, not so much for the patient as it is for the eye surgeon who is treating it, and you wish that the patient would go to somebody else, is Tigerson superficial punctate keratopathy. So there are many causes of punctate keratopathy. The one I am talking about is Tigerson's. The cause is unknown. Whenever the cause is unknown and you have to explain to patient, and they ask you, Dr. Sahab, aaj sa mate thayu, and you tell them that, well, you can't say I don't know, so the word to use is autoimmune. Autoimmune is a very good word to use because you say that it is your own body, so somehow patient feels that he is responsible. Doctor is not responsible. હું શું કરું તો મહેનત કરું પણ તમારા બોડીના અંદરથી તમારા પોતાના સેલ્સ આવે છે and they attack your own tissue. It is like an Indian thinking that there is a Pakistani sitting there and they attack. So your body thinks that your own cells are Pakistani and it is attacking. But don't worry, I will give you medicine. So patient now feels it is his fault and he will not blame you. It is not associated with any other, unlike other autoimmune conditions, not associated with any other ocular or systemic disease. It is a standalone disease by itself. Unlike viral keratitis, the sensations are normal. So you need to distinguish Tigerson's from other causes of SPKs. And there is never vascularization. Yeah, so this is typical Tigerson's. You can have pores, you can have fines, you can have sitting on top of the cornea, you can find them even affecting the anterior stroma. So it is usually chronic, it is usually bilateral, it may be asymmetric, there may be 5 in one eye and 25 in the other eye. It is punctate, it is epithelial, but though the classic textbook teachings is epithelial, I have seen it sometimes affects the superficial layers of the stroma as well. And may last for 2 to 4 years with exacerbations and remissions. So depending on your level of practice, if it is a busy corneal practice or it's a busy phaco practice, and you don't want the patient, you can tell the patient, I am aakta jao tipa, mane disturb nahi karta, and he will go to somebody else. But if your practice is like mine, where once in 15 days I get a patient to treat, I talk to the patient at length and try and keep the patient with me and tell him that it may last 2 to 4 years, but whenever there is an exacerbation, please come back to me, I will charge you 50%. Eventually it does heal without leaving any scars. It does not respond to topical antibiotics, does not respond to topical antivirals, and does poorly with debridement. So don't try any of these things which you can do in RES and which you can do in FK. But it has a dramatic response to steroid. Should we start steroid for everybody? The answer is no. So this is the typical clinical feature. It's quite symptomatic. Usually the deposits are intraepithelial, white to grey, dot-like opacities. And unfortunately, there is most of the time a predilection for the central area, but it may be evanescent. Evanescent means it comes and goes. It is in one area. By the time you finish drawing it in that area, it has gone to some other area, provided you draw once in 15 days. So treatment is low dose pulse. Local steroids can be tried. Tear substitutes. IDU is contraindicated. It worsens these things, so please don't use. Idoxuridine is contraindicated for everything, including for viral keratitis. So those of you who still have IDU in your armamentarium, please throw them away. We are blessed that in our country we get acyclovir available. In other countries they get the more expensive trifluthymidine available. But we have acyclovir and ganciclovir available with us. So there is really no place for IDU because it causes corneal toxicity in a very short time. Anything over 10 to 15 days and you get corneal toxicity which looks like SPKs. If very symptomatic, for some time you can give extended wear contact lenses itself. The recent advances, and this is something that I use very little of steroids. I deliberately put a brand name here. Tecliment is from Oralab. Unfortunately, I have no financial interest. Daily at night for 3 to 6 months in my practice, this Tecliment is the most well tolerated. Aside from there are competitors which are available, and some of the names that I can give is Talimus LS and Entrex Soothe LS. Oralab, Tecliment and 12 bottles of Orosporin, which I will talk about later. And I give it to the patient. It costs hardly 100-200 rupees. The other drug I love is Orosporin, which is 2%. So cyclosporin 0.05% is what you use for dry eye. Is what you can use for filamentary keratitis. Keratopathy, which is again something which is very poorly understood by many of us. There is no keratitis. It is a degeneration of the cornea, and it occurs only when the corneal sensation has been destroyed or has been reduced. So if the normal corneal sensation is there, you are not dealing with neurotrophic keratopathy. Simple as that. So although numerous ocular and systemic diseases may result in this, one common insult is a lesion of cranial nerve 5 orange branches. So there has to be absent or diminished corneal sensation for you to diagnose this condition. That's why it's called neurotrophic. So again, it is not immune mediated, it is not infectious. So please do not use any antibiotic in these patients. We have this love for prevention of secondary infection. We use this term for phaco-cataract surgery, for SICS, for keratoplasty, for anything. When we touch the eye, we put the patient for 6 months on antibiotics, and usually it is on moxifloxacin. What secondary infection? So after 1 week you need to stop antibiotics for everything. Even for my keratoplasty patients, after 1 week or 10 days I stop topical antibiotics. But I've seen other patients with keratoplasty done elsewhere for one year, they're on steroid antibiotic combination. So this is an overuse and abuse which causes more harm to the eye. So it's non-infectious, please don't use any antibiotics. So it's because of impaired corneal innervation, there is delayed epithelial cell turnover. The cornea innervation is required to have healthy turnover of cells. The old cells to be cast off, the new cells to come. We know the XYZ theory of corneal epithelial formation, where you get from the limbal stem cells tissue coming right to the basal level, then going upward, and changing the shape from the cuboidal to flatter and flatter until it becomes very flat, and then it is cast off, and then new cells come from. So this is what is called the XYZ theory of corneal epithelium, how it grows. So that requires good limbal stem cells, and it requires good innervation. If either of these is lacking, you get a problem with the epithelium, and that is why you get this neurotrophic keratopathy. You need an optimum blink. The patients, unfortunately, 50% of our people are now on computers. If they are not on computers, they are on mobile phones. Even our farming population is on mobile phones. So whenever we are on mobile phones or on computers, our tendency is that we are so afraid subconsciously of losing the data which is there on the phone or on the screen that we don't blink fully. We blink a little and then jaldi kholi nakhya kahi nahu to nathi aayo kahi some new porn stuff or whatever. So our blink frequency keeps reducing, and that again, that blink is required because God designed the blink not so that you could take rest in between a font clips, but God designed the blink so that the tears which flow from under the eyebrow, we have lacrimal glands situated over here, they have tubes which come into the eye, and when we blink, we think it is an up to down movement. Actually the blink starts like a zipper from the lateral, and the last portion of the eye to blink is the medial. So it pushes the tears across the cornea, and the excess tears then go through the puncti and down. So this is what God created. It is infinite wisdom. He didn't write it down for us. It required researchers to find that out. So when the blink frequency is low, there are islands of defect, islands where there is dryness. Wherever the blink has not become a proper blink, the tears have not gone to that part. It's like a windshield wiper in a Maruti 800 car, which is an old car with old wipers. So the wiper cleans, but only in patches. There are patches where the water is still there. So it is something like that in the blink frequency. So we need to pay attention. When a patient is sitting in front of you, there are three things to see. One is how well dressed the patient is, so that how much you can charge the patient for cataract. The second thing to do is to see whether the patient is blinking well. So when the patient is talking to you, see whether you can make out. You don't need an SBM or a big machine to calculate the blink frequency. You can make out whether the patient is blinking well. And the third thing is to see whether the patient is smiling occasionally or not, because otherwise 50% of your patients are in depression, and depression causes dry eye. So these are three things you need to look at when you're seeing patients. So the decreased tear secretion is often there in these patients, and we normally exacerbate the problem by chronic use of topical meds, no matter whether it is steroid or antibiotic or anything, but especially antivirals. We love using antiviral in this because sensation is low, it must be viral keratitis. So when corneal, how does it occur? When corneal denervation occurs, there is a decrease in acetylcholine. Acetylcholine is released by our nerve endings. Those acetylcholine is required for epithelial cell mitotic activity. So when you do a histopathology, you will find a decrease in epithelial cell glycogen. The cells swell, they lose their microvilli, loss of conjunctival goblet cells. All this happens. Goblet cells are important because the tear film adheres to the mucus. The mucus is the building block. Just like if somebody is building a building and the base of the foundation is not good, the building padi jai. So same way, the goblet cells are required to make healthy mucin so that the rest of the tears can sit there properly. So having said that it is not viral, it is almost 90% of the time secondary to herpes zoster or herpes simplex. So patient is given history. It could be due to surgeries or tumors that damage the trigeminal nerve, makes sense. Trauma again, which causes this. Infections like leprosy, which will again damage the nerve. So this is all given. Corneal dystrophies where the cornea is unhealthy, the mitotic turnover is not taking place. Topical medications that I told you, or toxic exposure to chemicals that can cause this. There is congenital syndromes like something called the Riley-Day syndrome. Riley-Day syndrome is familial dysautonomia, which is rare, but you have a problem with the innervation. Systemic diseases like diabetes, because overall there is a neuropathy in diabetes. Peripheral nerves, multiple sclerosis, again this is quite, as people are living longer, people are getting more of MS. Approximately 15% of patients where the eye is anesthetic due to any of these causes will develop neurotrophic disease. If some sensation is present, the more the sensation which is present, the less likely of neurotrophic disease. So it's important to distinguish between active viral and neurotrophic. That's why I'm spending a little more time on this. In active viral, there will be staining, which is either dendritic or geographic. We have seen those pictures, so I'm not showing you. With scallop borders, no specific predilection, it can occur anywhere. Etiology is an active viral infection, and the treatment is debridement if it is an epithelial disease, or you can treat with antivirals, and it should resolve in 2 weeks. Any epithelial viral infection should resolve in 2 weeks if your treatment is correct. But look at neurotrophic. The stain, initially there is only an epithelial defect, stroma is not involved. So first the epithelial defect will stain. In later stages, I'll show you the stages. Then this stroma will also get affected. The borders are smooth. See that picture there? It is horizontally oval. This is a typical shape of a neurotrophic keratitis. Horizontally oval shape. You don't get this horizontally oval shape in a geographic ulcer. It is usually between the upper lid and the lower lid, so interpalpebral area. It is, as I keep stressing, decrease in corneal innervations, drugs, toxicity, dry eye, or a combination of these. And the treatment therefore is lubrication is the mainstay. Stop all the other medicines including antivirals, and if it starts subsiding, you can do a tarsorrhaphy, you can do a tape tarsorrhaphy initially, you can do a surgical tarsorrhaphy, you can put, depending on how much you want the patient to spend, you can put gold weights in the upper lid to bring it down, you can do a Botox there to bring it down, bandage contact lens, and these have a chronic course. It's not going to go away in 2 weeks' time. So a gentleman with nothing better to do called Mackay came out with a staging system for this. Then he staged this into stage 1, stage 2, stage 3. So in stage 1, it's just that the palpebral conjunctiva is stained, the cornea is not staining, the reduced breakup time, increased viscosity of tear. So in stage 1, there is just a keratopathy, there is no actual staining. It's just that the cornea conjunctiva looks little dry, like you see over there, little leathery, maybe a few SPKs, roughened. 99% you will not see patients in this stage. So this is only for academic importance because I am wearing a suit and because I come from Mumbai to impress you. So you will not see most of these in stage 1. If you do see this patient in stage 1, the treatment is just like you would treat any other dry eye condition. If it is symptomatic, you might put a bandage contact lens. Oral doxycycline is good. When you give oral doxycycline for dry eye, we know that it works on the lid, it works on the meibomian glands, it reduces the collagenase, it reduces the MMPs. But the chemist doesn't know. So in the beginning, when I come back from the US, very fresh with this knowledge of doxycycline, and I thought I was the only one in India who knew about doxycycline preventing corneal melts. I used to write a lot of doxycycline, and I would write once a day for 3 months or once a day for 6 months. And patient would go to chemist and the chemist would say, doctor जो है ना अमेरिका से आया बहुत जल्दी में है, बहुत ज़्यादा patient है. Those days I had more patients. So एंटीबायोटिक है वो 6 दिन के बदले देखो 6 महीना लिख दिया. अच्छा हुआ कि आप मेरे पास आए. 6 दिन ही लेना. So I would write 6 months. Patient would take for 6 days and come back to me after 6 months. So when you write oral doxycycline, please tell them that you know little more than the chemist does, and 6 months is correct. Nowadays, of course, you have to write it in capital, so you are less likely to make a mistake, but tell the patient it is for 6 months or 3 months. And punctal occlusion is good. Autologous serum helps in many conditions. This is one more. In stage 2, now the epithelium is lost, stroma is still intact. So there will be a ring of loose epithelium around the epithelial defect. So just around there, the epithelium all heaped up, as if they're all people looking into the well, and there is somebody who's fallen in the well, and there are 100 people looking, nobody is helping. So it is like that. The epithelium is heaped up all around, as if they're looking down to see the tamasha. And the stroma is a little boggy, but the stroma is not ulcerated as yet. So treatment here, contact lens is contraindicated. Gently debride all those rolled up edges. The spectators which are standing over there are doing no good. So remove those spectators. So scrape those off so that healthy epithelium can come from the side. You can do temporary tarsorrhaphy or Botox. You can put an amniotic membrane in these patients. Autologous serum is one of my favorites. So you will see that it comes in almost all the talks that are, all the conditions that I'm talking about. There are experimental treatments with epithelial growth factors. There is something called Synergermin or oxynervate, which is developed in Europe only so that a particular company can make money, because the treatment cost for 6 weeks treatment is about 5 to 6 lakh of rupees just for those drops. So it is rather that you treat surgically and charge even 1/10 of that amount. So luckily it's not available in our country. So in stage 3 now the cornea starts showing stromal lysis. This is stage 3. The cornea is now perforating. There is total innervation loss. You are flooding the eye with antibiotics. You are doing all the wrong things, and the stroma starts thinning out, and you can get a melt. So you can get a stromal perforation. So here you need urgent tarsorrhaphy for these patients, or Botox to the upper lid, topical antibiotics, because by now you can give antibiotics because it's perforating. It is good chances of infection over here. Steroids will further thin the cornea, so avoid that. I would do a conjunctivoplasty here, or I would put an amniotic membrane to save the eye. And if the perforation has not occurred, or if it's less than 2 millimeters, you can use cyanoacrylate glue with a bandage contact lens in these patients. So the tears in neurotrophic keratitis are low. There is decreased blink rate, decreased, even the reflex tearing is low, decreased aqueous tear. The main issue is the watery component, which is less. So the viscosity of the tears may be quite high. Another thing which makes a considerable difference, though it is a little expensive, is the Boston scleral lens, the large diameter 18 to 22 millimeter scleral lenses which are there. So what is different is that what is a scleral lens? It is like a chai ka saucer. Over here you give tea only in glasses, but in Mumbai we have something called saucers also. So the tea cup is there and there is a tea saucer. So in that saucer you put the water or the saline. So you put the water there. So when you put it with a plunger, you hold the contact lens and put it there. So the saucer is fixed over the cornea without touching the cornea, and the saline is continuously bathing the cornea. So it is good for keratoconus and for other things, but it is also good for neurotrophic, because the patient, as I told you, the aqueous component is deficient. So it is continuously bathing that cornea with saline, and every 6 hours or so you can remove and put fresh saline over there. So it allows oxygen, very high oxygen permeable, what we call high decay value for those who use contact lenses. And this is the dramatic effect. You can see this before scleral lens and after the scleral lens, a dense white, dense staining area is become much less, and the stain gradually reduces. Though the cost of the contact lens, it costs about 50,000 rupees for a single contact lens. But neurotrophic is otherwise a difficult condition to treat. What we can do at least is what we must not do. And again I stress, there is no role for antibiotics unless there is an impending perforation. There is zero role for any antivirals. Moving on from neurotrophic keratitis to something which we see very frequently and which we mistreat equally frequently, and that is allergic conjunctivitis. So a little bit on allergic, and then I'll tell you why I treat the way I treat allergic conjunctivitis. So we know about these papillae which are there. We know that this is basically a hypersensitivity response, where there are airborne allergens. It could be dust mites which are there, we have this fancy allergy testing. I do get patients allergy tested, provided they've got at least 2 out of 3 allergy parts in the body. One is an allergic skin disease like psoriasis, or an allergic asthma along with an allergic eye. If they've got these, then I ask them to get allergy testing done, 80 allergens, 160 allergens, depending on how much you spend, and then they find out what the allergies do, and then they give you small doses of that to boost your immunity, and then they keep giving you for 3 months that allergen subcutaneously, and it is supposed to reduce your sensitivity to this. Just for allergic eye disease, I think it's a bit of an overkill. Most of the patients are not willing to undergo, because allergy testing itself is quite a painful exercise where they make small cuts on your arm, 80, 160, whatever, to test. So we know that the allergens come and sit on these Y-shaped receptors that you could see over there. So they sit on the Y-shaped receptors and they push on that Y-shaped receptor, and then those Y-shaped receptors then push the mast cell. They're sitting on top of the mast cell, and the mast cell then releases those granules which it has got. And when those granules are released, then the pro-inflammatory cytokines are released, and the whole cascade starts. So this is how receptor binding with the antigens, that's the Y-shaped receptor, causes degranulation of the mast cells, and the mediators contained in the granules are released. This is an artist picture of the mast cell which is releasing the granules. It doesn't look as pretty as in the picture. So what are the mediators which are released? You get tryptase, heparin, histamine. Histamine is the most powerful. They are released into the extracellular matrix, that means outside the cells. And this starts a new cascade of biochemical events leading to new mediators coming, like prostaglandins and leukotrienes. Leukotrienes excite or suck out the WBCs from the blood vessels, passing blood vessels. So they activate the vascular endothelial cells, which causes release of further chemokines from the bloodstream and influx of inflammatory cells, the neutrophils and the eosinophils into the conjunctival mucosa from the blood. So one little dust mite causing so much of a cascade which occurs. So what are the treatment options that we have? Let us start with simple things that we can all do. The first one is impractical. In the US, when I was over there, on the radio, they used to have announcements. Today the pollen count is so much, and all patients with allergy are advised to stay indoors, because pollen was the most important cause of allergy, or is the most important cause in the US. In India, it is dust mites and pollution. You cannot stay indoors with dust mites and pollution, because where will you go? In indoors also it is there. But in the US, so they used to have these announcements saying pollen count is so much, don't stir outside. So otherwise it's impractical to put people in plastic or glass cages. Cold compresses helps. You get on Amazon, you get 300, 400 rupee masks which are there. Most people have refrigerators. You tell them to put the mask in the refrigerator, not in the super fridge but down. And whenever the child is complaining of itching, just let him wear the mask, like in an airline you wear a mask to sleep. And that cold compress helps. If you can't do that, take ice in a handkerchief and apply it on the lids. So the itching, the symptoms of itching reduces quite well. And this is something very easy for the mothers to do. And also you're giving the mothers something to do. So the mothers feel they're fussing over their children. So psychologically it helps the mothers as well. Sunglasses is something which is again useful. Children love wearing sunglasses, fancy sunglasses. The tighter the sunglasses fit, the less their ungli will go in and rub. So the sunglasses is not so much for the appearance, but see that they are tight fitting sunglasses so that they will not put their fingers in when they go out. And improving hygiene, teaching children the importance of when you come back from playing, just wash your hands with soap and water. We taught them during COVID, but we have forgotten that now. So simple things like don't rub your eyes with dirty fingers and things like that. So these are simple things that all of us can practice. Then many times in chronic allergic conjunctivitis, there is an element of dryness which creeps in as well. How do we know this? If the patient is also complaining of a sandy or a burning sensation. A typical pure allergic patient will complain of itching and foreign body sensation. But if he is complaining of a burning sensation or a sandy sensation, then there is possibility that there is coexisting dry eye, and there is no harm in adding lubricants to the treatment. don't put it for everybody lubricants, because too many drops makes the child resistant to any drops. So many times the child gets fed up of the number of drops the mother is putting and then refuses all drops except the steroids. So long-term treatment with mast cell stabilizers, symptomatic treatment with antihistamine drops. We have drops which are pure antihistaminic, we have drops which are pure mast cell, but it makes more sense now that we have drops which can do both to use dual action drops. And topical cyclosporin, as I told you, I do use 2% orosporin if the child can tolerate, or 1%, or tacrolimus ointment at night. Systemic drugs in very, very few, very rare cases. Up to now I haven't spoken a word about steroids. So we are still not on steroids. So mast cell stabilizers, the first ones we got were cromolyn sodium, 2%, 4%. They're given up now. Then modoxamide came, which was 250 times more potent than this. Somehow it never came into our country. And then these other ones were also there. But none of these are freely available. I just mention it again, as I said, because I'm suited and booted and have come from Mumbai. None of these are pure mast cell stabilizers. They don't have any antihistaminic effect. And then there are pure antihistaminics like levothyroxine, imidazoline. They block the histamine receptors, so they prevent the itching. And luckily for us, these are also not available. So pure mast cell stabilizers and pure antihistaminics are not available. So we are using now what is called dual action drugs, which are both mast cell stabilizers. So they stabilize the mast cell. That antigen is coming into that Y-shaped receptor, it is pushing the granules out from the mast cell, but the mast cell ka darwaja band hai, hum nahi jaane dunge type of thing. So the degranulation becomes less. So, and they are potent H1, we know the commonest leukotriene, the commonest exciting inflammatory agent is histamine. So they block the H1, they're H1 blockers. And examples available are ketotifen or ketorolac, which are available. Brand names Ketlur LS, Acular LS, these are available. Olopatadine is the one which came in. First it came in as twice a day, then it came in as once a day, and then it came in as something called Max. So that they were not sure whether to use 0.2%, then they made it 0.1%, then they made it 0.2%, and then they made it 0.7%. We never really know what the pharma is telling us, we just swallow it. And bipotestin is bipotestin basinate, which is the Ophthalmic original multinational which came in. It was from Bosch and Lomb, it was called Bipriv, and it is 1.5%. And they found this trial and error that 1.5 was superior to 1%. And the only issue is that the dosage is twice a day, while L-captidine is once a day. So bipotestin mast cell stabilizers, a dual action agent. We won't go into all the pharmacokinetics. Again, this is just to impress you with how much depth I've gone into in research for this. But they did studies and compared it to placebo, which is very easy. When you compare something to placebo, obviously it is better. So useful, it concluded that 1.5% is useful for managing ocular itching associated with allergic conjunctivitis. And then they compared it with olopatadine. And of course, since the research was done by the company making bipotestin, they concluded that bipotestin was superior to olopatadine. If olopatadine had done the research, you would have got exactly the opposite effect. So they, according to this company which makes bipotestin, patients prefer bipotestin over olopatadine by 2:1 ratio for treatment of allergic conjunctivitis. In practical life, some of my patients are happy with bipotestin, some are happy with olopatadine. So it just depends which one is happy. You need to get the patient back and tell them if you are not happy with this, we'll change you over to something else. What about steroids? Only in very severe refractory cases, always as a supplement to therapy. You can use it as a pulse therapy for say every hour for 3 to 7 days in very, very severe cases. And use the milder ones, fluoromethalone, loteprednol, diluted dexamethasone. Monitor carefully and ensure compliance. Counsel the patients on ill effects of the steroids and scare them a little bit. There is a surgical treatment as well, where you can, if the conjunctivitis, if the allergic conjunctivitis is mainly palpable, then I scrape off that entire palpable with a Bart-Paka knife. I scrape that off, and then I used to take, if the bulbar conjunctiva was not affected, I would take a piece like a pterygium autograft and take it from there and glue it to the upper palpebral. And when I glued, in the beginning I was gluing only the part where I could scrape off the middle 2/3. And then I found that I was getting fresh papillae on the sides where I had not done. So now we do the whole conjunctiva. Whole conjunctiva is difficult to get so much of tissue, so you can use amniotic membrane instead of the patient's own tissue. And I found that there was something preventing, some preventive substance in the bulbar conjunctiva which was preventing the papillae from occurring. That's why it was occurring only in the palpebral. So that's why I feel that the bulbar conjunctiva is superior to amnion when you are doing a transplant in these patients. So to summarize, what I do for patients is I typically put them on topical alcaftidine or bipotastine or olopatadine, and I tell them to continue for 2 years. Irrespective of whether there is allergy or no allergy, itching or no itching, just continue. Why do we continue? Because allergens are all around in the air. Even if the patient is not getting itching, the allergens are coming in, they are pushing onto the mast cells are releasing granules. Now, if we can take care of have less number, you cannot have 100% success, but if less number of mast cells are releasing granules, then the threshold is not reached for the patient to start itching. They are proven safe even if we use them for 5 years at a stretch. So I tell the patient to use it for 2 years, and in the assumption that even if he doesn't come back to me, at least for 2 years he will use. If he does come back to me, I have stretched it for 5 to 7 years. Patients have been continuously on these. There's no steroid in them, there's no other side effect in these. So I tell them to continue these drops. I give them Acular LS or Ketmur LS 4 times a day and tell them to use it when there is itching and till the time that itching is continuing. So if there is itching, so he's putting alcaftidine or bipotastine, and in spite of that now he's getting itching. So then you put the patient on these dual action, weaker dual action drugs, which is Keratopathy LS or Acular LS, and he's putting those drops up to 4 times a day, maybe 10 days, 15 days. I tell them as long as there is itching, you use it because it doesn't have any steroid. Suppose he's using these drugs for 3 times, 4 times a day, and in the first 3-4 days the patient is still itching a lot and there is no effect. Then I tell him you put loteprednol 3 to 4 times a day for 3 to 5 days maximum. Note down which dates in the calendar, and for 30 days after that you will not use it again. And along with that loteprednol, you continue the Acular LS. So loteprednol brings down the threshold and the Acular LS then starts taking effect. If this combination is not working and he is still itching, then tecliment at night is added. If that is not enough, then orosporin in the morning is added. So 1 drop of orosporin in the morning, 1 drop of tecliment at night. With this step ladder approach, I have found very little abuse of steroids. My patients very rarely are on more than 3 to 4 times a day steroid for 3 to 5 days in a month. So the chances of dry eye, glaucoma, cataract are much less. I thank you so much for your attention so far. Survived much beyond this. He was extremely fit, and to show how fit he was, he did 50 push-ups on the stage during that last, before he started that last lecture. He was only 49, he did 50 push-ups. I am 67, I cannot do 1 push-up also. I have had a USG abdomen done. As of now, I have no liver tumors detected. But the concept of last lecture then came in from there, that the last lecture is something which traditionally a person gives when he is speaking nothing but the truth and is speaking only from personal experience, and is sharing his experience with the world, assuming that he is not going to be there for very long. Since none of us know what the old man upstairs has got in his book as to how long we are here, let us assume, and going with the same thought, I am sharing some of the thoughts, some of the things that I have learned over the last million years or so that I started my practice, and sharing them with you. These are all absolute truths from my point of view, and you are welcome to take as many take-home messages from these as possible. So first of all, apologies, I do love seeing my pictures on the screen, and I try and put them up as much as possible, especially my pictures which are 10 years earlier than this, when the hair was much blacker. So let me share with you some values that I believe in, and this is what I'll be talking to you about. The importance of goal setting, consistency, standing for our convictions, the karma theory, the importance of valuing ourselves, asking for advice, and always being ethical. And I'll try and illustrate these with some of the examples. So first one is goal setting. You need to have a long-term vision, but set realistic short-term goals. You cannot be a first-year medical student and have a short-term goal of acquiring a Mercedes car by the time you get finish your MS. So that's not realistic. But realistic short-term goal is that I will become good, or I will master slit lamp, or I will master indirect ophthalmoscopy. That's fine. Long-term vision, that Mercedes car can be in the long-term vision, but your goals are different from your vision. Your vision, yes, is to be a multi-millionaire, but your goals are to acquire skills and set short-term goals, achieve that and set another one. Don't think about failure, be positive. Tiger Woods in his prime days, before he started sexually assaulting women, he never thought about failure. Every time he hit the ball, he would imagine the golf stick in that hole over there, and no matter how far it was, he would be focusing only on that, and that's why he became one of the best golfers of all time. Fear is an illusion. We imagine obstacles instead of opportunities. So if you see a typical Hindi movie, where the hero, always on a white horse, is galloping towards the cliff, he doesn't look down into the valley, he sees the opposite side, and the horse makes a wonderful chalang right across the cliff and lands safely on the other side. While the pose of villains who are following the hero, they stop at that cliff and they can't cross across because they are worried about the chasm below, the deep valley below. So don't look at the obstacles, look at the positive side across always. There is a story of the king's falcon in the good old days in the Middle East, where the rulers, the emirs, would have hunting falcons. The falcons would be prized possessions of the emir. There was one particular falcon who refused to fly, and the king called all the wise men and asked them, can you make the falcon fly? And some tried to bribe the falcon with all sorts of foods and push the falcon a little, but the falcon would not fly. Till one gardener came there and said, can I try? And everyone laughed at him. And this gardener came with his sickle and simply cut the branch on which the falcon was sitting. And the falcon flew because he had no choice. So don't wait till you have no choice to fly. Just start flying on your own. The second is of consistency, the importance of consistency. You need not be the best person in the batch. You need not be the smartest or the most charming or the most popular, though I was all of these. Just be consistent. Just be consistent with what you are doing in your behavior and approach. Unlike the carpenter, there is a story of a carpenter who was a master carpenter. He was coming close to retirement. He went up to the boss and said, I would like to retire. I have worked for you for 40 years. Now please give me my pension or whatever is due to me, and Ram Ram, I won't go jump. And the boss said, there is just one more house to be built. I want you to build that house. I know you are my master carpenter, only you can do it. So he gave him the outline of the house. This carpenter was so disgusted with the boss that I want to retire, he's not letting me retire, I will show him. So he made a house which was the worst house he had ever made. He was always consistent up to now. But now he made a house which was designed to fall at any time. Looked palatial. And then went over and gave the keys to the boss and says, now can I retire? And the boss said, yes, you can. And giving him back the keys, he says, this is the keys to your house. I know no one could build a better house than you could. So this is the keys. May you live long in retirement in this wonderful palace you have built. So you're not consistent when it counts. So sometimes what happens is that we have a busy OPD. Not like me, as I said, I get one patient every 15 days, but for those of you who have busy OPDs and know what it's like, you must be as consistent in your examination techniques with the first patient as you are with the 150th patient of the day. Because by the time the 150th patient comes, you feel that just dot mark ke dekh liya, nothing is there, you put refresh tears, go. for that patient, he is the first patient that he is coming to you, you're the first doctor that he's seeing. So you have to be equally consistent. If there is a pattern you follow of history taking, slit lamp examination, dilated pupil, you have to follow the same pattern for every patient. Only then will you make a name for yourself. So it's not just working hard, but being consistent, which will help. The third thing that I would share with you is the importance of standing up for your convictions. Now this is more for students who, for example, are asked to do a thesis topic. And the thesis topic could be anything. It could be the comparison between chondroitin sulfate and methyl cellulose in FECO or whatever. And you read something and you find out that chondroitin sulfate is better according to published literature. But in your series you are getting sodium hyaluronate. Don't fudge the results and make it chondroitin sulfate because the world has said chondroitin sulfate. There could be confounding factors in your thing. And remember that if you publish something which is already well known, you don't get any marks for it. But if you publish something and stand up for those convictions and prove that you are right, you become a hero. So if something is going against the grain, all discoveries have been made because people were not following the same beaten path. Extracapsular cataract surgery was the norm till Harold Ridley decided to put a lens implant. He was completely criticized. They didn't give him space, they would not allow him to speak in meetings. The Sir Stuart Duke Elder, people who were like his gurus, would ridicule him and say that I would never put this lens in anybody, only put it in your enemies and things like that. That was the criticism that Sir Harold Ridley had in 1949-50 when he started this. But he stood for his convictions. Because he stood for his convictions, we are here. If he had listened to that criticism, okay, this will never work because seniors have said this anecdotally, then we would never be doing intraocular lenses today. There is the example of a company chief executive officer who wanted to appoint a successor. So he gave each, there were 8 or 9 people who could possibly succeed him in the company, senior vice presidents. So he gave all of them some bamboo seeds and told them to please grow a bamboo plant at home and in 3 months come and show me the result, and depending on how well you have nurtured that bamboo plant, I will choose my CEO. And all of them took the seeds home, and 3 months later all of them came with lovely looking bamboo plants, each taller than the other. Only one gentleman came with an empty pot. So the others started laughing at him and saying, what happened? You didn't know how to grow a bamboo plant. Somebody said, I spent some money, I hired top gardeners and I hired this. And the CEO came out and said, I have found my successor. It is this fellow who has come with an empty pot. And all the others asked, what happened? How did you choose that? He says, I gave you all boiled bamboo seeds. You could not have grown any bamboo plant from them. So all of you have cheated. Your bamboo plants didn't grow. You put some other bamboo seeds, and this fellow was honest. His plant didn't grow. He tried his best. He came back with the empty pot. So stand for your convictions. That is what will make you and set you apart from other people. The fourth thought I would share with you is give without expecting a reward. We have this enshrined in our holy books. We don't need anyone else to teach us. In our Gita it says that you work towards a goal and don't bother about the gifts to follow. Somebody will know the Sanskrit. I'm very poor in Sanskrit, so I can't say it, but that's the basis of the karma theory. So do what you think is right without bothering for a reward. There was this gentleman called Paderewski who was a very good piano player, and there were 2 impoverished students, Herbert Hoover and a friend of his, and in college, when they were in college, they decided to raise funds for their college, and they hired this Paderewski and told him that we will give you $100. This is in 1920s. We'll give you $100 and you play for the college, just like we have variety entertainment programs to raise money. So they called Paderewski, who was already a world famous pianist, but as is usual with college students, they're not interested in classical piano. So the program was a flop and they couldn't raise any money. So they had only $25 they had collected. They told Paderewski, we are sorry, but we have got only $25. We have not been able to raise any money for the college, but even for you. So he said, forget about it, it's all right. Theek hai, chale chale. Years later, Paderewski became the president of Poland. He migrated to Poland, he was president over there. Poland had a huge famine and there was no money in Poland to get any grain. So Paderewski went over to the US and appealed to the US president to help and said, we'll pay you later. And Herbert Hoover, who was the president at that time, sent him grain by the shiploads and says the grain has already been paid for. I get emotional when I hear these stories. Sorry. Then the importance of valuing yourself and others. Again, in college, many times we are criticized, everyone else is doing a perfect indirect ophthalmoscopy, we somehow can only see the disc, we can't see the whole tears which are over there. And the professors shout at us, you'll never make an eye surgeon, tu kabhi sudrega nahi, or your hand is so terrible, you'll never be able to do phaco. So we get depressed, we get despondent, and we really feel that we are no good. Think of yourself as a crumpled 100 rupee note. You take a 100 rupee note, you crumple it as much as you want, you put it on the road, let 20 cars pass over that note, then you take that note to the mall and you buy 100 rupees worth of goods, they will give you 100 rupees worth of goods. So that note has not lost its intrinsic value. So no matter how much people trample on you, no matter how much people curse you, criticize you, you must have that sense of value which is in you, which no one can take away. So we are all diamonds within, waiting just to be polished. Somewhere you'll get somebody who will polish that diamond for you. Henry Ford, who became a very famous industrialist, in those days, no matter who you were, in your childhood you worked for pocket exchange, for pocket money. So he was a milk delivery person. And he was asked afterwards, when he became rich and famous, what did you learn when you were delivering milk from house to house? See, in those days, people would keep the milk containers outside and the milk vans would come and the milk delivery boy would take the big spoon and pour it into the container. He says, I learned one thing, that some containers were shallow, like plates, some were bottles which they had kept, some were big vessels. But no matter what the size and shape of the container, the cream always rose to the top. So no matter what happens to you in life, if you are in the cream, if you imagine that you are in the cream, you will rise to the top. So value yourself, never let anyone belittle you. Ask for advice. No man is an island, we are all part of a team, nobody knows everything. So when you don't know or when you can't solve something, don't take on something which is beyond you. If you are not doing keratoprosthesis and a patient comes to you for that, don't say that I will do it for you, because it's not in your competence. You will burn your fingers and earn a bad name. So do whatever you can, learn more so that tomorrow you can do that procedure. But as of now, if you feel that somebody else can do it much better than you, then don't be afraid to send the patient across to somebody else, or ask someone to advise you on how to do that procedure, how to solve this problem, or if you are in a diagnostic dilemma. And be receptive to criticism. So this is the beauty of teamwork. And this is what sometimes friends tell you, X, where is X? There it is. And be ethical. It's more profitable in the long run to be ethical, because people will realize you can't fool people all the time. You can keep talking about laser surgery and robotic surgery and artificial intelligence surgery, but somewhere or the other people are going to catch on that this fellow is talking rubbish. And important thing is that all of us have to be role models for our children. There are very few role models left in the world. If you see our politicians, they don't fit into that role model category. If you see our film stars, they don't fit into that role model category. People like Sam Manekshaw, people like Abdul Kalam are very few and far to find. And our children have never heard of them. What children will see and hear is what you do and see. I remember when we went to an amusement park, my father paid for a full ticket for me, as I was just above the age limit by a few months for a half ticket. And my uncle was there with us, and he asked him why, because he's short, chal jata tha, he could have paid, got a half ticket. He says, and they said the ticket checker fellow would not have followed, because in the US they go by a height restriction also. तो उसको कभी मालूम नहीं पड़ता था. He says उसको नहीं मालूम पड़ता था, but मेरा बेटे को याद रखता था ना. He would have remembered that this is possible. And I was once caught talking on the cell phone at a traffic signal. And it was genuinely, I was paused at a traffic signal. My hospital had called up. There was some emergency about the patient and I was chatting. I tried to tell the Havaldar, I am a doctor, emergency tha. And I said, Gadi band pada tha, signal pe tha. He says, the law is the law, you are not allowed to talk while you are in the vehicle on the driver's seat, which is technically correct. So he gave me a challan. Unfortunately, that same day, Salman Khan or somebody ran over some 10 people and killed them. So they changed the law overnight. And previously the challan, my driver could have gone next day and paid the money and got the license back. But now I had to go to court and stand in the witness box. So that was, the court is one small causes court where there were 9 taxi drivers and I was the only one suited and booted over there. And the judge asked me and I said exactly this crime. He said, no, but you are guilty. I said, yes, I am guilty. So he said 7 days, you cannot drive for 7 days, license confiscated for 7 days. So I genuinely did not drive for 7 days. My kids were younger, they wanted to go and have ice cream. I said, I am not driving, we'll take a taxi and go and buy ice cream, but I am not driving till those 7 days are over. Whether they learned the lesson or not, I don't know. To summarize, I discussed the importance of certain values in our personal and professional lives. I assure you I have not told you anything I don't follow myself. And of course, you are free to apply any or none of the take-home messages in your own lives. I thank you so much for listening to part 2 of 3 parts. Moving from the ophthalmic I had to do to justify the RMB oration and the airfare that you have spent. The ethics part was something that I wanted to do because I said if there are postgraduates, I want to now start teaching ethics and these values to people, at least what I follow. But when I see Manibhai Chotalia in the audience, then humor comes to mind. And the importance of humor in everyday life. You see, many of us feel that why should we be humorous or why should we be cracking jokes all the time? Man is a selfish animal. I am a Rotarian. In Rotary there is service above self. That is nice as a slogan. But as far as we are concerned, man is a selfish animal. We prefer ourselves to anybody else. So it is a known fact that when you laugh, you release those small protein molecules called endorphins. And when you release endorphins, you're supposed to live to be 300 years old. And you don't get dementia and you don't get Alzheimer's. So there are a lot of fringe benefits of releasing endorphins. So if that can happen when you laugh, in fact there was a gentleman called Dr. Mathur-Nagpal-Baldha in Bombay. He started what is called laughter clubs, where they would meet in parks and they would come out with artificial laughter at 6:30 in the morning. Ha 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 ho ho ho. And they said that exercises your diaphragm and everything, plus releases endorphins. Unfortunately, he had 20 court cases against him for disturbing the peace. So it is not required to go at 6:30 in the morning to a public park and disturb other people to laugh. But it is important to crack jokes whenever possible. Once you understand that it is not important for the samewala person to get the joke or to laugh himself. If they laugh, it is bonus, their endorphins are released. But you are not doing it for their endorphins, you are doing it for your endorphins. So if that is the principle behind it, then it doesn't matter, no matter what kind of joke you crack, or if 50% of people don't follow your joke, it doesn't matter, as long as you learn to laugh at your own jokes. So all of us can learn to laugh at jokes. But there are few do's and don'ts about humor that you must follow. First is start with short jokes. So for example, you say, did you hear the joke about the blonde who won the chess tournament? And then laugh. When you laugh, that samewala person feels the joke is over. Then he scratches his head, isme kya joke tha? Then he says, blonde who won chess tournament, blonde is supposed to be dumb and she won the chess tournament, so that's a joke. It's not very funny. But you have laughed, you have released your endorphin. Wo ghar jaake hasega, that is his problem. So start with one-liners like this, blonde who won the chess tournament, and laugh. If you want to tell longer jokes, then you must develop a very good hand grip. You must go to the gym and develop a good hand grip. I had a friend called Dr. Vihang Vaya, psychiatrist in Bombay. So he would meet me in several hospitals. We were attached to the same 3 or 4 hospitals. In the morning he would meet me, Quresh, you heard this one? And he would hold my hand over here like this. His grip was so strong that I could not release that. So then it did not matter if I had heard the joke or not. I could not run. So he would tell me the joke. Unfortunately, after Bridge Candy Hospital, he would meet me in Bhatia Hospital. Quresh, you heard this one? I said, Vihang, you told me this in the morning. He would proceed to tell me the joke again. And I had to laugh, or not laugh, but the hand grip was there. So, second principle in life, start with short jokes, then if you want to tell longer jokes, then have a good hand grip. The third principle when telling a joke is know whom to practice the joke with. So, ideal are children if they are pre-teen, if you have children who are pre-teen, or grandchildren who are pre-teen. Because before they turn 10, 11 years of age, they love you so much that they laugh because you laugh. So irrespective of how complex the joke was, they have not understood, but Nana or Dada has laughed, or Dad has laughed. So they will laugh. So they are your best audience. So you can practice your jokes with grandchildren and children. One person you must never practice your jokes with is your spouse. Because 110% he or she does not appreciate your sense of humor. I am a Bori, we have this arranged marriage system. So about 1 million years ago, 42 years ago to be precise, I was by a matchmaker introduced to my would-be wife. And first time I met her, I found that she was attractive and likable. Second time I was convinced that she is the right lady for me. There was no, because the matchmaker is the person you have to ask. So my mother asked the matchmaker, she said there is no response from the girl's side. We are allowed maximum of 3 to 4 meetings. After that, you go to somebody else. So third meeting, same thing happened. I came home, I told my mom, I told my sister, okay, this is 100% the girl for me. No response from the girl's side. We had to plead with the matchmaker to allow one more meeting. She says, last meeting. I decided to play my trump card. And I took her for a walk and I decided to tell her joke after joke because I thought my humor was fantastic. There was very little response. I was sweating. And at the end I said, you know, her name is Sajada, it still is Sajada. I said, Sajada, we've been meeting 3 times so far, this is the 4th meeting. I have been told that this is the last time. I really like you. And, is there anything you find attractive about me? I mean, because we will not be allowed any more meetings. She says, you know, I have been chatting with you, you're clever, you're intelligent, you've introduced me to your friends, all your friends also, I introduced the right group of friends. Your friends also seem to be very likable people and they regard you well. Everything is good. The only thing I can't stand about you is your sense of humor. So against all odds, I had to plead with that matchmaker that I'm getting 75% marks, which is more than pass. Please allow one more discussion, and so then we are still married 42 years. But that opinion has not changed. So I can never tell her that I'm going to be speaking something humorous anywhere because she says, don't crack those silly jokes all the time. So don't practice on spouse because they are no good as far as appreciating is concerned. And the language is not important. It can be in any language that you are comfortable. You can crack jokes if you are comfortable in Hindi. You can crack jokes in Hindi. Like the lady who sent her child across to the neighbor and said, go and ask that lady for sugar. So that little child, girl went over to the neighbor's house and said, "Maa kehti hai aapke paas shakkar hai to do." Now that lady didn't like the way that this child had asked. She didn't say please, aapke paas. The tone was not right. So he said, I'm sure this is not what your mother has taught you. Tell me exactly what your mother said. Hoping to get the words please and other thing. And the child, being innocent, said, "Ya maa ne bola us chudel ke paas se nahi mile to baju wale ke paas se le." The joke would be in Gujarati because certain jokes sound better in the language. So there was the teacher who was teaching maths and was teaching the children, and she gave the boy a sum. Suppose you have 4,000 rupees with you. Tamara paase 4,000 rupiya hoy. અને તમારી તન બેનવો હોય અને તન બેનવો તમારા પાસેથી પૈસા માંગતી હોય અને તમને વોટ્સએપ કરે કે મને પૈસા જરૂર છે, તો તમે કેવી રીતે આપશો આ પૈસા? તમે એન્ડ ઓફ ધ ડે માં તમારા પાસે કેટલા પૈસા બચે? So the boy said 4,000 rupees. Saying how? Saying I'll have 4,000 rupees and 3 missed calls. Then don't crack jokes on religion, because certain things people get offended with is jokes on religion. For example, don't crack jokes like the one which I'm about to tell you is about the Sunday school teacher in a church. So the one Sunday school teacher, pretty young thing, was in the church. आप वो उठाएंगे, उसके बाद में बात करूं? भाई साहब आवाज ओछो करो. So the Sunday school teacher was a pretty young thing, was standing at the bus stop, and gentleman passed by and he said, can I give you a lift? And she said sure, and he picked her up. He says, you know, you teach religion very well, my children are very happy, and would you like a smoke? He's trying to make her comfortable. She says, no, if I smoke, what will I tell my Sunday school class? Okay, sorry. They go a little further and they come to a motel which has a bar. So he says, if you don't mind, I'm thirsty, can we go in? So they go in and he says, would you like to have a drink? She says, no, if I drink alcohol, what will I tell my Sunday school class? This fellow says, yeah, dal galne wali nahi hai, but let me try, no harm. So then he says, look, they've got rooms by the hour over here. If you want, we can go up and have a good time. So she says, sure. So they go up and they have a fantastic time. They come back in the car. This fellow is wondering. He says, man, I asked you for a smoke. You said no. I asked you for a drink. You said no. And yet you came up with me. What will you tell your Sunday school class? He says, very simple. I will tell them you don't need to smoke or drink to have a good time. And there was this nun, pretty nun, who was being picked up again. Many of these things happen when people are being picked up. So she was being picked up on the street by one of the parishioners, one of the Christian men, and he found her very attractive and his hormones started getting the better of him. So he put his hand on her knee, and when he put his hand on her knee, he said, sir, please remember Psalm 139. This fellow said, Lafra, he moved his hand out. After some time he started feeling those hormones again, and he put his hand again on the knee, and she says, sir, please remember Psalm 139. And he was very flabbergasted, so he took his hand out, didn't do anything, dropped her to her church, went back home, immediately opened the Bible and looked up Psalm 139, which said, go further and thou shalt find what thou seeks. So important thing is to know whatever religious book you are following. I showed you a video about tattooing for those of you who had come in early. That reminds me of a story. There was this lady who went for a tattoo job, and she wanted the tattoo artist to tattoo on her left inner thigh. She wanted to have Diwali crackers and Diwali lights tattooed and the word Diwali written. And on the right inner thigh, she told the tattoo artist, please put a Christmas tree and some jingle bells and a Christmas written over there. So the tattoo artist said, I will do whatever you say, but this is a very strange request. I have never had such a request. On one inner thigh you want Diwali, on the other thigh you want Christmas picture. Why is this? He's saying, I'm fed up of my husband always saying there is nothing to enjoy between Diwali and Christmas. The jokes really come out of everywhere. I remember the first day when I was in medical college, and we have this main lecture theatre in KEM Hospital in Mumbai, and it's theatre style seating from down to up, lower stall to balcony type of seating. And the professor, on the first day of our entry, he asked, what is it that expands to 10 times its size when excited? And there was a girl from a small town called Latur in rural Maharashtra, and she got up from behind and said, sir, I am going to tell my father and I am going to tell the dean that you are teaching very dirty things. And I come from a small town, I have been brought up very conservatively, and I don't like the way you're teaching such dirty, dirty things. So this professor was unfazed, he looked at her and says, young lady, please understand you entered medical college, no part of the human anatomy is dirty, dirty, number one. Number two, your knowledge of anatomy and physiology is extremely poor. I was talking about the human pupil. And number three is you're going to be extremely disappointed when you get married. We moved on, and I passed my exams. I became an eye surgeon, and I live on the 11th floor. By that time I'd become a Rotarian, and I was standing in the balcony at about 6 in the morning with my hands outstretched, thanking the Lord for all the favors done. I wasn't doing it, but it sounds nice when I say it. So I put my hands out like that, and suddenly I felt something falling into my hand. And I looked at it, it was a glass eye. And I looked up, and there was this neighbor in a transparent negligee bending over a balcony. I was a Rotarian. Rotarians is always do good to others. So at 6:30 in the morning, I rushed up to her house and I rang her bell, and she pulled me inside and says, come quickly inside, my husband is not at home, he's on a business trip. And then she asked me, what will you have, coffee, tea or me? And I chose the third option. And then we had a good time till I tell her, okay, ma'am, I have to go, I've got surgery now and my anesthetist will be waiting. But I just have one question. I said, are you that hospitable to everybody, to all your neighbors? Or is it me, something in me? She said, no, only to those that catch my eye. And then I started my practice, and I shared the waiting room with my father, and we shared the secretary also. And then I thought that Dad's secretary was 40 years with him, so I must get a new secretary. So I got a younger secretary. And I stood behind the pillar while the two secretaries were exchanging notes. And they were discussing the boss. And I was wondering which boss they're talking about. And one secretary said to the other, our boss is so handsome, so suave, and he dresses so well. And I was feeling so thrilled for myself. I said, wow. Until the other secretary says, yes, and so quickly too. And I realized I shouldn't have been listening to this conversation. In Mumbai, we get a lot of shortage of nurses. I don't know whether you have qualified nurses, is always a problem. So in my nursing home, I wanted a nurse. And most of our nurses come from the deep south of India. And this nurse had come from the deep south, and her certificates were very good. I wanted to employ her. And being typical Guju from Surat, I asked her, what salary will you take? She said, no sir, you tell sir, you tell sir. So I said, no, you tell. Typical thinking that if she tells, it might be lower salary than what I will offer because she is qualified. So for some time it went on, you tell, no sir, you tell sir, no you tell. Till finally, very blushing, she said, sir, 6,000 rupees sir. Now 6,000 for Bombay standards was very cheap. So I was very thrilled. I said, 6,000 with pleasure. She said, no sir, with pleasure, 25,000 sir. And I was interviewing a male for the office secretary, and we ask the same questions to people. So I told him, when you go out, I tell them, since we are asking the same question, don't discuss the question answers. But it is human tendency. So he went out adjusting his trousers, and the people outside asked him what happened. He says, no, boss is very good. He asked very simple questions. I was doing very well in the interview. Saying, then what happened? He said, I don't think I'm getting the job. He's saying, but you are asking, boss, simple questions and you are answering. He says, yes, then boss asked me to show my testimonials, and I think I showed the wrong thing. So little bit of English knowledge is important when people are applying for the jobs, is what I always feel. I will end with one for the road. We had friends. In those days, there was something called ECFMG and VQE, where if you wanted to go and practice in the US, you had to pass these qualifying exams, US qualifying exams. So this classmate of mine had gone abroad, made his million, and then typically came back to get married to a Guju from Bombay. And the father had made the wedding card, everything was printed, only the name of the bride was left blank because in 1 week he saw 12 girls, selected one, and they got married and he went back to the US. Now this girl, first time she goes, it's a palatial house, $1 million mansion, and in those days, I'm talking about 35 years ago, he had got that dish antenna, very good catch cricket, because he was the cricket before Netflix and satellite TVs and all that. So he had got special equipment. So he was watching cricket over there. His newly married wife comes up to him and says, darling, I have a small problem. When we climb the steps, there are 4 steps to climb before we enter the house. So as we climb the steps on the front porch, the second step is a little loose. So I'm afraid if I climb with heels, then my heel might get caught in that, I might fall, I might get a fracture. If you can fix that step. See, over there, even if you're a millionaire, it's not like here you can call a carpenter or a plumber. You don't get service. Small things you have to do yourself. So he got annoyed with her. He says, can't you see I'm watching cricket, you're disturbing me. You think I got Acme hardware written on my head. You think I'm a carpenter. Don't disturb me. She was very upset. So she decided to be smart and she waited till there was the drinks interval. So during the drinks interval, she came up to him and says, darling, one more thing. In the kitchen bulb on the top of the ceiling, that has fused. And you know how I cannot stand heights, so you need to climb the ladder and change the bulb. So again he got very annoyed. He said, you think I've got Philips written on my head? You think I'm an electrician? You're really troubling me. Don't do this. Newly married wife, she goes away. She waits till it's the lunch interval over there. Now there is nothing happening over there. So she goes up to him and again, third time she makes a request. Okay, you know darling, the refrigerator door, the gasket is come off a little bit and the things inside will not stay cold for long. If you can just put some Fevicol or something. He says, you think I've got Pidilite written on my head, you think I'm some refrigerator engineer, you're annoying me so much. I'm going down to the bar or down the road, I'm going to have a drink over there and I'm going to drown my sorrows with other people, watch a little bit of cricket there and then come back. She's by now crying away to glory and he leaves her. When he goes there, has one drink, has a second drink, then he realizes that he has perhaps been a little too harsh on her because after all she's newly married, first time she's come to the US and these are all genuine problems. So after a couple of drinks, he realizes that he should apologize. So he comes back home. When he comes back home, he climbs the steps. The steps are perfect. There is no creaking sound. There's no loose floorboard. He goes into the kitchen thinking he'll get a beer, puts on the light comes on perfectly, opens the refrigerator to pick out a can of beer and finds the refrigerator door is perfectly stuck. Now he's sweating a little bit. He comes up to the wife and says, darling, exactly what happened while I was away from here. He says, you know, I was crying buckets and buckets of tears sitting on the front porch and our kindly neighbor Mr. Smith came by and he asked me, why are you crying? And I told him of all the things I'd asked you to do and how you would do it. And that is why I was crying. And our kindly neighbor was so kind that he offered to do all these things himself. And the husband, now sweating profusely, says, and what did you have to do for him in return? She says, he asked me to either bake a chocolate cake for him or have wild and passionate sex. And he says, what kind of a cake did you bake? And she says, you think I've got Monginis written on my head? You think I'm a baker? Thank you. Spoken or not spoken?
Keratoprosthesis. Something about keratoprosthesis.
Okay. Can I share some video? Or?
Yeah, sure.
Not for vision restoration because after this you can't do anything. So it's sometimes quite heartbreaking that you do a keratoprosthesis and then you end up with a complication and then you can't do anything further. So usually we do it only for patients who have got only one eye and when everything else has failed. It's not the first resort. So eye donation, this talk was given during COVID time, but I have done a dozen Boston K-Pros during the COVID time because that time we had only poor quality corneas available with us. And I have done Pintucci's also. The Pintucci where donor cornea is not required. So there are many different K-Pros in the market. The ones most widely used are the Singh Verse champagne cork keratoprosthesis. It's like a champagne cork. It has got holes, and stainless steel wires are used to fix it to the sclera. The good thing about it can be done through the cornea. It can also be done through a scleral window. So Dr. Daljit Singh has done it where the cornea is badly fired. He puts it through the sclera. So patient gets eccentric fixation but does get fixation. The problem with this is that there is no proper peer-reviewed literature, because he has done, the late Dr. Daljit Singh, at that time, I remember a conference in Gujarat itself about 15-20 years back, where I had presented data of 20 Pintucci keratoprosthesis that I had done with about 30 different complications. Every patient had got at least one or more complications, and his daughter Indu Singh was there. And that time she said, we have done 20, we have done 2000 Daljit Singh K-pros, but there is no complication. So when the attitude is like that, then you can't really advance science. So I have no knowledge of the Daljit. I have not seen a successful Daljit Singh K-pro over here, but there must be many going around. Then the MOKP of Falcinelli. There were two giants in Italy who did not talk to each other. One was a chap called Strampelli and one was a chap called Pintucci. So Strampelli and Pintucci both went their own ways. Strampelli made the bone, the osteoodontokeratoprosthesis, OOKP, where you have to take the canine, drill a hole in it, put a plastic PMMA cylinder and then put it in the eye. And Pintucci said this, taking the tooth is rubbish because you can't do it in children because they don't have permanent teeth and you need a dental surgeon. So he devised the Pintucci keratoprosthesis where there is a PMMA cylinder with a Dacron mesh like a medu vada around, which is made of Dacron, which is a cloth, and inside there is a cylinder which is PMMA. So the cloth is sutured around and the cylinder remains to see. Falcinelli was Strampelli's chela, so Falcinelli modified the OOKP and called it the MOOKP, Modified Osteodontokeratoprosthesis, which is the one which Christopher Liu, his student in UK did, and then it went to Hong Kong, and then Shankar Nethralaya started doing the MOOKP. The Pintucci KP is with a Dacron mesh stud, so it was no longer after Pintucci died. Pintucci died of stress. Italians are crazy people. One fine day he went home and found he was a multi-millionaire. He had his own yacht, his own sailing boats, he had his own plane, that kind of. His father was the inventor. Pintucci was younger than me. He would have been about 58, 59 today if he was alive. So Pintucci one fine day went home and found his brothers. His brothers used to own the company which made the K-Pro, and he would operate. And one fine day he found his clinic closed and he couldn't open it with his chabi, very Hindi filmy style. And he asked the watchman, they said, "Aapka bhai log ne chabi band karke rakh diya hai." So he was thrown out of home and clinic both. Luckily at that time he had a girlfriend. He had finished 2 wives and he was now with a girlfriend. So he went and stayed with the girlfriend that night and then continued to stay with her. And then went to Kenya for safari to try and drown his sorrows. Got a massive heart attack there and died. So Pintucci K-Pro. So after that we tried making it in India. So gentleman who helped me was an ocularist called Chavan. So we called it the Quresh Maskati Pintucci K-Pro because Pintucci was dead, so usko zyada bhav dene ki zarurat nahi thi. Chavan made it, so I had to put his name first. And the other K-Pro is the Dolman of the Boston K-Pro, of which I've been doing since 2009, courtesy Dr. Tony Aldave from California, who came and taught us the procedure. So every opaque cornea cannot be offered a K-Pro. Corneal transplant gives good results in a majority of cases, lamellar and full thickness. In infective keratitis, you can't do a K-Pro, so only a natural cornea will save the eye. Later on, you can do a K-Pro if it is 360 degrees vascularized, there are no stem cells, you can do a Boston K-Pro in this. And successful corneal transplants have a much better field of vision than K-Pro. They have full field of vision, while my K-Pro, my Pintucci K-Pro has got only about 30 degrees or 40 degrees field of vision. And on that I was blamed. Once I had gone to Malaysia to do a Pintucci K-Pro. This is again in the 90s or early 2000s. Pintucci is done in 2 stages. The Boston K-Pro is done in a single stage. So this was a Dudwala Bhaiya. He was a Malayali origin, but 300 years his forefathers had settled in Malaysia. So he used to go early morning with a milk can to deliver milk everywhere, 4 in the morning. and somebody by mistake on this Dudwala threw acid thinking that he was somebody else, some rivalry. So he had acid burns, he had 18 surgeries done to both eyes before I saw him. And then I saw him, I did the Pintucci Keratoprosthesis, and he, after that I went again 2 months later, did the second stage. In the first stage you keep it under the lower lid, then you take it out and put it, so it biointegrates. The skirt which is there, blood vessels go into it, and then it biointegrates, so then you take it out and put it in the eye. So after the second stage his vision was 6/18. The story doesn't stop there. At 5 years later, I got a call from Professor Veera Ramani from Kuala Lumpur to say that your patient of Pintucci Keratoprosthesis died. I said, I'm so sorry to hear that. She says, you're aware that it was your fault. I said, I'm sorry, but what happened? So she was annoyed with me. She says, you gave him 6/18 vision in that only eye. He resumed his work of vending the milk, but you didn't tell him about his field of vision. So he was crossing the road at 4 in the morning with poor peripheral field. A truck came from there, it was dark, the truck driver didn't see him, he didn't see the truck driver, he knocked him off, vehicular accident, he died, all because you put a Pintucci. If he was blind, he would have been alive. So moral of the story is, if you are doing keratoprosthesis, you have to have a strong heart, because you are blamed for complications of the Pintucci. if you make your own keratoprosthesis, you die of stress, and otherwise your patient dies and you get blamed for it. So the indications of a Boston K-Pro, because Boston K-Pro is a much easier thing. So any vascularized failed graft, any opaque cornea with stem cell deficiency. The important thing is that the tear production should be good, the tear secretion should be good, the lip blinking should be good, lip apposition should be good. So you cannot do Boston K-Pro for a Steven Johnson patient, which is the lot of patients you get with Steven Johnson with bone dry eyes. You can't do that. You can do a Pintucci, but you can't do a Boston K-Pro. You need good tears, and a B scan should show that there is no optic atrophy, because you can't see anything inside, but there should not be deep cupping. I have burnt my fingers when patients insisted. I have done a Boston K-Pro for them, and then found there was 0.9 cupping with glaucomatous optic atrophy. Then they, after 6 months of giving them vitamins and all that, they saw 6/6, but through absolute pinhole vision. But then it's not worth sometimes the risk. So for Boston K-Pro, those with poor tear secretion like this keratinized eye, you cannot refer. Patients like this, you cannot refer. Those with history of previous corneal bends, you cannot refer. This is the patient I had referred to me for K-Pro. I need a Pintucci for this in the right eye, but you could not do a Boston over here. Very severe chemical burns. And if there is poor lid lids or malopposed lids, you can't do a Boston K-Pro. There you can do Pintucci. But contraindication for all K-Pros, patient unable to follow up with some eye doctor. So patient should follow up well. So there was this patient I did in Lahore in 2007. Again a case of chemical burns. I had done a Pintucci. She saw well for about 5 years. Then she got a retinal detachment over there. And she was from a rural background. She didn't go to a doctor for 6 to 8 months. By the time she went to a doctor in Lahore who did a B scan and said there is a retinal detachment, she had a closed funnel retinal detachment. I managed to get visas for her, took her to Shankar Netralaya. I flew myself to Shankar Netralaya to try and help. They did the best possible. With the closed funnel lasting over 6 months, there was no visual recovery. So anybody who cannot follow up, not necessary to follow up with you, but at least if you have a friend where they can follow up with and will report to you, that is essential for any K-Pro. So importance of compliance to treatment regime is important. And of course, since I am in solo private practice, the third point is equally important as far as I am concerned. So these are some of the lovely results. Chemical burns pre-op, and this is the Boston K-Pro with sutures in. This is the 1 day post-op appearance. The cosmetic appearance is not so bad. Post-op vision can be 6/6, and this is a patient with sutures out. Good amount of the more the vascularization, the better, because the eye will be held better, leakages will be less. So you need to evaluate these patients. Visual acuity, many times when very dense opacities, you don't get perception of light in all quadrants. This is a trick taught to me by Tony Aldave, that if persistently you do 10 times and nasally the projection is good, the other projections are faulty, but nasal projection, every time you shine the torch nasally, he is able to pick up. Still you can go ahead with this. I have not seen it in any books, but I have followed this like that, because sometimes if the B scan is normal and the patient, because the opacity is so dense, hardly any light is going in, somehow he feels that this works. So patient can be phakic, pseudo-phakic or aphakic, it doesn't matter. But if it's pseudo-phakic, if it's a well done pseudophakia, then you can leave the lens in place. Otherwise it's better to remove that lens and make him aphakic. If it's not a PCIOL in the bag, then remove that lens, make him aphakic, and you can put an aphakic K-Pro. So in Boston K-Pro there are two types available. One is pseudo-phakic, which is 45 diopters in power, fixed power, doesn't matter axial length. And the second is aphakic. So if it's a cataract or it's a clear crystalline lens, or you're going to remove the IOL, then you go for the aphakic mode where you have to give them the axial length. Depending on axial length, they prepare the K-Pro cylinder of a particular power. So A scan is important in aphakic cases, or those you are going to make aphakic. So these are the parts of the K-Pro. There is a mushroom shaped PMMA front part like a screw. Then you need a donor cornea. Donor cornea with a central 3.5 millimeter hole through which that screw goes in. And then there is a back plate which has got 16 holes. You fix that over there underneath. And then there is a titanium locking ring. It's like a bangdi which is broken. So that locking ring fits over there and it clicks into place. So these are the four parts out of which the corneal graft is supplied by the eye bag. It doesn't have to be a good quality cornea. It can be the worst quality cornea, because it doesn't matter. You don't mind the cornea becoming opaque, because he's not seeing through the cornea, he's seeing through that cylinder which is there. So these are the patients, vision less than 3/60 with similar poor vision in the other eye. So these are the patients, and I keep reiterating, patients should be able to afford my cost. So this is the first patients which we did in 2009. This was the first patient I chose, was a patient who had divergent squint. I said amblyopia है, try करने में क्या जाता है, नहीं दिखेगा, नहीं दिखेगा. So this is the patient that we did with Dr. Anthony Aldave assisting. He is a brilliant teacher. When I did my first K-Pro, he was assisting, and I told him, sir, you do the K-Pro because we will observe you. He says, nothing doing, you have done Pintucci's already, there is nothing, I will assist you. So he sat on the assistant side while I did the K-Pro. So this is the K-Pro in place, and this fellow got 6/12 post-op in spite of the divergent squint. This patient, Anthony Aldave told us not to do, but at that time we had, Maha Mushkil se, we had gathered 3 patients for the demo. So this patient had a history of corneal melts, and she was on methotrexate. He says it is a contraindication. Autoimmune disease is a contraindication. She got 6/18. As of now, she is 6/60 vision from 2009 to 2023. She's still got 6/60, but she's got melts. I have put sclera around over there to the cornea. She's been on high doses of immunosuppressives, but it was her only eye. The other eye was optic atrophy. Can we play the ये वीडियो प्ले कर सकते हैं? नहीं तो बाहर निकल के प्ले करो. बाहर निकलो. हाँ, तो बाहर निकलो, वीडियो है बाहर. वही फोल्डर. First one. VLC, VLC. So this is just how it is assembled. So this is a flaring ring which has been put. This is a aphakic cornea. So it comes in 2 sizes, 7 millimeters and 8.5 millimeters. So if it's a 7 millimeter, then you do a 7 millimeter trephine. If it's an 8.5, you do an 8.5 of the patient and half millimeter more of the recipient. So this is the patient's, the donor cornea which has been taken. Central 3.5 millimeters punched out with a punch. So this is the punched out thing. That's a sticky material on which you put it there. Put some methyl cellulose. In those days we had 8 hole black plates. Now we have 16 hole black plates. Holes are so that the aqueous comes and nourishes the endothelium. This is a pusher. It just pushes the back plate into place. This is the titanium ring which is there, and then you push it again so that you get a snap-on effect so that it holds well. दूसरा वीडियो लगा रहा प्लीज, आपको जरा इधर आना पड़ेगा. So this is how it is assembled. So this is many times we do a glaucoma valve procedure at the same time in these patients. So this is an Ahmed glaucoma valve being put in a patient, being sutured into place just like you would normally put a valve. And you cover it with anything. You could cover it with pericardium. I normally use sclera. Close it first. Then do the cornea. So you do a peritomy. You mark the center of the cornea. The stem cell doesn't matter here, so you don't have to worry about it. So either, as I said, 7 millimeters or 8.5 millimeters is this trifine. If it's an adult, you normally go for 8.5 millimeter definition. You mark the center. You can make those radial markers. This is the already assembled, this is the K-pro, like an inverted mushroom. There's a sticky tape which comes if you get it from Boston. Orolab makes it, somehow they can't make the sticky tape, they make everything else. This is the donor cornea. So donor cornea, if it's an 8.5 definition of the patient's eye, then it is a 9 millimeter definition of the donor. You can use whatever trifine you want. And this is the central. You must make sure that the hole in the center, which you are making 3.5 millimeters hole, is exactly in the center. So you can mark the center so that the light focuses on the macula. So this is with the hole made in the center. You put the methyl cellulose. You don't need expensive HA or anything. So you fix it on that mushroom with the screw. That cylinder is pointing towards the ceiling. This is the 16-hole PMMA back plate. It is little concave. So you put it there, and then with the pusher you push it into place. It's just a pusher. It comes with the sterile pusher comes with it. This is again just showing the pusher. And then you put the titanium back plate. This is the titanium back plate which is cut. It comes pre-cut like that. So you put it there, and with the pusher you push it into place. It goes there with the click sound. It must go well over the stem so that even if you lift it like that, it doesn't fall out. Now it's ready. You put it back in MK medium and proceed with the patient's eye. I put it normally in a vati with MK medium. This is a suction trifine, but as I said, you can use whatever trifine you are used to. So this, if that was 8.5, this is a this is an 8.5 definition. If the pupil is not dilated or it doesn't dilate, then you can make small iridotomies at the pupil because you want a nice big pupil. This is the Ahmed glaucoma valve which you can trim if it's too long, making some iridotomies. So that even if your PMMA cylinder is little eccentric, the pupil is wide enough so light will go through. So then you suture, because your donor cornea is 0.5 millimeters larger than the recipient, you can suture fairly easily. So I normally take interrupted sutures, but you can take, as in keratoplasty, you can take interrupted and continuous, whatever you like. That's just a piece of tissue kept to prevent unnecessary light toxicity. And the rest is just tailoring techniques, suturing technique, just like a keratoplasty. And this is, you bury the sutures as you would for any penetrating keratoplasty. and this is how it looks at the end of the procedure. And important thing is we put a scleral contact lens, minimum 16 to 18 millimeter scleral contact lens every 3 months. They recommend every 2 months, but cost effectiveness, we recommend every 3 months. We change the scleral lens and put a new one. So each one costs about 500, 600 rupees. And the patient is on antibiotic drops for life. So this is the only case in which they, over there they use topical vancomycin drops. We find it expensive, so what I do is I put them on topical moxifloxacin 1 month, 1 bottle. When that bottle is over, they go for high strength gatifloxacin, 2nd bottle. When that bottle is over, they used to go for becifloxacin, 3rd bottle, or now we go for levofloxacin, 1.5, which is available. So every month they change the antibiotic. Summer Basak and others, when they do, they find more fungal infections post-op. So every 3 months they treat the patient with amphotericin B for 1 week. I don't do that. In my series, the fungal cases are not so much post-op, but this is just to prevent. So when Dr. Dolman, who is now 102 years old and still alive, his grandson is doing Kpros, but he's still alive with an active mind. I met him 2 years ago when he was 100, and I could discuss complications of Kpro with him. Amazing man. So, the antibiotic drops for life and the scleral lens for life. So you have to tell them that your costs will continue. So when you give them a costing, you have to give them a costing that you will have to put drops for life, and that at every 3 months you will have to change your contact lens.
Cost of the procedure?
Cost of the procedure depends on whether the patient has got a Louis Vuitton bag or the patient has got a Tata product bag or something like that, shoes, kaisa pehante hain. So there are several criteria which are used. None of them are ophthalmic and none of them I can really discuss with you. But having said that, we do it free of charge as well, because unfortunately bilateral blindness is something which doesn't affect the rich. It affects the poor. It is the poor who become bilaterally blind. So I never do free cataracts, but I do free Kpros for patients, because we know that there are patients who can't afford. But as far as referrals is concerned, please refer those of the Ambani-Adani status. He's gone for lunch. 5-minute video. In Pintuchi, it's what we have to take buccal mucosa. So this is like a calazion clamp. It's a buccal mucosal clamp. I hold it there. I cut the buccal mucosa. It includes a little bit of the orbicularis oris muscle also. I take it out and then I trim that. It shouldn't be too thin. It is not like pterygium autograft where you thin. The thinner the graft, the better. It should be a little thickish, because the buccal mucosal graft I put into the eye, and that thins out with time. So this is quite a bloody surgery. You need general anesthesia, you need suction, you need a good assistant, and I typically stop this bleeding with hydrogen peroxide. So I take gauze soaked in hydrogen peroxide. This is the type of patients in whom we do Pintuchi. So it's ankyloblepharon, where you can't even open the eye. So first I have to open the eye with 2 stairs which are superior and inferiorly, and try and find the eyeball. So this is, we are opening the eye, finding the eyeball. Once we find the cornea, then I take a suture with tenno nylon in the center of the cornea, because later on I will need to find the center of the cornea later. And I try and find all the 4 recti muscles. So I isolate the recti muscles. The reason is that I know that blood vessels grow along the recti. All the 4 recti have got blood vessels coming. So I want that buccal mucosa to be put and to be vascularized. So I suture the buccal mucosa to the conjunctiva, whatever I can find, but I take one suture to the muscles, because I know that this buccal mucosa is a free graft. It has got no blood vessels of its own. So unless new blood vessels come and grow, this buccal mucosa will melt in no time. So it is sutured to the conjunctiva, it is sutured, a few sutures are taken to the 4 recti muscles as well. So you have to isolate the 4 recti and take sutures there. So this is in stage 1. So I am putting the buccal mucosa there, and then I am putting the Pintuchi keratoprosthesis, which is like a medu vada, as I said, or a can-can dancer skirt flared up with the PMMA cylinder. I put it under the lower lip. So this is, I have closed this, I put the buccal mucosa. So if patient saw moving body he sees less now because now there is a thick buccal mucosa on top. You have to tell them. So here I am putting the PMMA cylinder with the Dacron mesh under the skin and orbicularis of the eyelid, lower eyelid usually. In some patients I have had the skin and the lids also burnt. So I put it under the deltoid muscle in the arm. It doesn't matter, it just needs a vascular area. So blood vessels and fibrous tissue can grow. I close this in 2 layers, Vicryl for the orbicularis oculi and any silk or something for the skin. 2 months minimum you have to keep it in place. After 2 months you open, you can feel the bump over here. In the patient who had kept it under the deltoid, I told him, I marked it with a pen and told him, Jumme se Jumme hi nana. He was a Muslim fellow. So told him to have a bath once a week and then to put the cross mark again, otherwise I would have to fish through the whole deltoid. So because you couldn't feel the bump. Under the lower lid you can feel the bump. So now when you take it out, that Dacron mesh, which was a cloth tissue, has got blood vessels and fibrous tissue growing inside. There is no empty space. So here now when you open the eye, you see the buccal mucosa was quite thick, now it has become quite thin. So I reflect the buccal mucosal flap little less elegantly than you would reflect a Lessig flap. So with a hinge. I prepare for a tarsorrhaphy in patients in whom there is very poor tear secretion. Otherwise, if there is a little bit of tears, you don't need to do a tarsorrhaphy. Because he is going to look through the central 30 degrees. So it doesn't matter if the medial and lateral tarsorrhaphy is there. Because here there is no bandage contact lens. So you find the plane and dissect the buccal mucosa and reflect it down on one side, upper temporal or lower temporal. So this is how it's reflected. The Tenno nylon suture I took in the center of the cornea helped me to find where is the center. Then I do a definition, 4 mm definition, partial thickness. Then I take 3 radial cuts, 12, 4 and 8 o'clock. In Pintucci you have to remove the lens, you have to remove the iris. And when I am doing this, I pull on the ciliary body, causing cyclodialysis cleft, so that the pressure in the eye falls, so that there is no secondary glaucoma. In a Pintucci, no valves are ever put. So here I am pulling on the iris. This is intracapsular cataract extraction. Dr. Baldha will remember this. Intracapsular cataract, I still preserve the cryo. And this is the Pintucci now. The 3 radial cuts are sutured. The Pintucci is sutured to the sclera. Then the buccal mucosa is sutured on top. And then a small opening is made in the buccal mucosa, so that the Pintucci projects out like this. And it is possible for the patient to have 6x6 vision through this Pintucci cylinder. But it's a laborious process after 2 months. And because of me, Shankar Netralaya has published a paper of a series of 10 retinal detachments following Pintucci K-pros. So out of my first 80 K-pros, Shankar Netralaya restored vision in 10 of them. So my detachment rate was roughly about 10%. The first patient which I had detachment, Dr. Natarajan operated, but then Dr. Natarajan has the nasty habit of charging for retinal detachment surgery, and since patient is already broke after paying my fees, he couldn't afford Natarajan. So the next 9 patients went to Shankar Netralaya, where they did it free of charge for the patient. And then they wrote a paper on it and published it in Retina. My only condition was that my name should be there, because if I hadn't caused the detachment, what would you have operated? So many of these get complications. I've had buccal mucosal melts happening. I've taken the frontalis muscle and pushed it, tunneled it from here and taken that and put over there to try and keep the K-pro in place. I've had a patient who complained to me that it doesn't look as sexy as a Boston K-pro. So she complained to me, she was a middle-aged lady who complained to me that when I go to play rummy with my friends, they all look at my face and it looks very funny. I said, ma'am, you are PL. You are now playing rummy. So but she was in depression. So she contacted Dr. Pintucci in Rome at that time to complain about me and asked whether she could come to Rome and whether he could do something cosmetic. So he rang me up and says, will you please do something for her? I don't want her coming to Rome. And then I asked Chavan to make a cosmetic shell over there for when she played rummy. So we have unusual problems. If a patient sees, the patient complains of cosmesis. If the patient sees too well, then he gets knocked down by drugs. And as I said, there are a lot of occupational hazards of doing this. I don't recommend Pintucci Keratoprosthesis to be taken up by any of you, but the Boston K-Pro is less hazardous. So let us start with something like that. Thank you so much. Thank you. Thank you, sir. Thank you. Thank you. Thank you. Thank you, sir. Thank you. Thank you.